my dear friends. So, as a part of the continuation of the endocrinology series, in this session, we will be discussing the very important topic, that is thyroid disorders. So, in the thyroid disorders, first what you need to know is the basic physiology of thyroid hormone and as well as the regulation of thyroid hormone. So, let me just give you a brief introduction of the thyroid hormone, and then I will move on to the discussion of thyroid disorders, that is hypothyroidism and as well as the hyperthyroidism. So, thyroid hormone is the hormone which is being produced from follicular cells of thyroid gland. Now, this particular thyroid hormone which is released from the follicular cells, majority of it will be T4, and even T3 is also released, but majority of it which is being released is T4, that is tetraiodothyronine. But among these two, which is biologically active form, it is your T3 which is biologically active form. Right? And the T4 is the one which is released in excess circulation, and this T4 will undergo deiodinization to form T3. So, this is the basic introduction to your thyroid hormone which is produced from follicular cells of the thyroid gland. Now, you see the regulation of the thyroid hormone secretion. We have the hypothalamus, this hypothalamus, it will produce thyroid releasing hormone, and this thyroid releasing hormone, it acts on the anterior pituitary, right? It acts on anterior pituitary, and in response to that, the anterior pituitary will release thyroid stimulating hormone, and this thyroid stimulating hormone will act on the follicular cells of the thyroid gland, right? Will act on the follicular cells of the thyroid gland. In response to that, T3 and as well as T4 is being produced. So these are the steps in the regulation of the thyroid hormone secretion. So for suppose if T3 T4 levels are increased, what it will do? It has a negative feedback mechanism. That is, when T3 T4 levels are increased, that will inhibit the TSH secretion and that will also inhibit the TRH secretion. So now please remember this point. When T3 T4 levels are elevated, right, there will be decrease in the TSH, there will be decrease in the TRH, that is thyroid releasing hormone. In other way around, for example, if there is decrease in T3 and T4 levels, what will happen is there will be inhibition of the negative feedback mechanism. So TSH and TRH increases. That is about the regulation of thyroid hormone secretion. Now, the other important point you should know is the steps in the synthesis of the thyroid hormone. So, if you take steps in the synthesis of thyroid hormone, please remember the first important step is the iodide trapping. So, in this iodide trapping, it is your I minus that will be trapped into the follicular cells, right? That will be trapped into follicular cells, and this I minus is trapped into the follicular cells through a symporter, and this particular symporter is sodium iodide symporter. So through sodium iodide symporter, I minus is trapped into the follicular cells. That is the first step. That is called iodide trapping. And second important step is oxidation of the iodide. Right? Oxidation of iodide, where I minus is converted into I0 or I plus. So this is called iodonium, where there is oxidation of iodide. And third important step is organification. So in organification, your iodide or I plus, in organification, I0 or I plus, that will combine with thyroglobulin, right? That will result in monoiodotyrosine or diiodotyrosine. That is your organification. Then followed by that, the next important step is coupling, right? So in coupling, what will happen is monoiodotyrosine will combine with diiodotyrosine to form T3. Then diiodotyrosine will combine with diiodotyrosine to form T4. Okay, so this is what is your coupling. So these are the three next important steps after your iodide trapping. Now, what is the enzyme which is required here? For oxidation, organification, and as well as coupling, what is the enzyme which is required? The enzyme which is required is thyroid peroxidase. Right, the enzyme which is required is thyroid peroxidase for oxidation, organification, and as well as the coupling. And you take the last step. In the last step, you have the release of the T4 and there will be deiodinization. So in deiodinization, what will happen is T4 is converted into T3, right? In the presence of enzyme 5-deiodinase, right? In the presence of enzyme 5-deiodinase, T4 is converted into T3, and your T3, it is biologically active form. Right, T3 is your biologically active form. So these are the steps in the synthesis of thyroid hormone, out of which thyroid peroxidase plays an important role in the major steps in the synthesis of thyroid hormone. Now after having discussed about the steps in the synthesis of thyroid hormone, you should know about the thyroid stimulating hormone and as well as what will happen to your thyroid stimulating hormone in hypo and hyperthyroidism, and what is the property of your serum binding proteins. Now, this particular T3, whatever is being released into the circulation, or T4, whatever is being released into the circulation, they go and bind to the plasma proteins. Now, let me tell you or let me explain you about the basic physiology of thyroid hormone binding to the proteins, and later on we will discuss in detail about the T3, T4, TSH. So, as already I have said you in the synthesis that T4 is the one which is being produced in excess quantity than compared to that of T3. And how many folds? Almost like 20 folds. Okay, so T4, it is produced in excess quantity then compared to that of T3, almost like 20 folds. And once they are released, both of these hormones, they are bound to the plasma proteins. Now, what are those plasma proteins? They are bound to the TBG, right? TBG stands for thyroxine binding globulin. Right? And second important plasma protein it gets bound is to transthyretin, that is TTR, right? So this TTR, which is transthyretin, formerly known as thyroxine binding prealbumin, right? Thyroxine binding prealbumin. And third important protein your thyroid hormone bound is to the albumin. So to these particular plasma proteins, thyroxine binding globulin, transthyretin and as well as albumin, the thyroid hormone is bound. Now, once the thyroid hormone is bound to the plasma proteins, the plasma binding protein increases the pool of the circulating hormone, right? So whenever thyroid hormone it binds to the plasma proteins, what do we call this as? We call this as the bound form, right? And whereas the form of thyroid which is not bound to the proteins, that we call it as the free form of thyroid. So the plasma binding proteins, they will increase the pool of circulating hormone, right? They will increase the pool of circulating hormone. That is one thing. And second thing is, this particular bound form, they will also delay the hormone clearance. Right? They will also delay the hormone clearance, because the proteins which are bound to the hormone, they will not allow, the proteins will not allow the clearance of that particular hormone. So they will delay the hormone clearance, and they will also modulate the hormone delivery to the selected tissue sites. So this is like basic introduction, that is serum binding proteins and as well as thyroid hormone. But out of which you take the thyroxine binding globulin. The concentration of thyroxine binding globulin is relatively low. Compared to that of your albumin, the concentration of thyroxine binding globulin, it is relatively low. It is just only 1 to 2 milligrams per deciliter. But this thyroxine binding globulin, even though it is, the concentration is relatively low, it has high affinity for the thyroid hormone, right? So this has high affinity right? It has high affinity for the thyroid hormone, right? Which one? T4, it has very high affinity compared to that of T3. So this thyroxine binding globulin, because it has high affinity for the thyroid hormone, it carries almost, right? It carries almost 80% of the bound hormones. Right? It carries almost 80% of the bound hormones. That is the thyroxine binding globulin. Then you take albumin. Albumin has relatively low affinity for thyroid hormone, but the plasma concentration is high. But the plasma concentration is high. How much is the plasma concentration of the albumin? That is around 3.5 grams per deciliter. Right? That is around 3.5 grams per deciliter. And this particular albumin, it binds up to 10% of T4, and this albumin, it binds up to 30% of T3. Right? It is bound to 10% of T4 and 30% of T3. That is about the albumin. But the plasma protein which is having the highest affinity is your thyroxine binding globulin, right? Then next we have transthyretin. So transthyretin, what is another name we have discussed? It is also called thyroxine binding prealbumin. This transthyretin TTR, it carries about 10% of T4. It carries 10% of T4 but little T3. So this is about the affinity of your thyroid hormone to the plasma protein. So to summarize this, what I want to tell you is, the plasma protein which is having the highest affinity for thyroid hormone is thyroxine binding globulin, right? Almost 80% of thyroid hormone is bound to the thyroxine binding globulin. Now, what is the abnormalities is that, for suppose, when the effect of various binding proteins are combined, right? When the effect of various binding proteins like thyroxine binding globulin, transthyretin, albumin, when the effect of various binding proteins are combined, 99.98% of T4, 99.7% of T3, they are protein bound, right? They are protein bound, and because T3 is less tightly bound than T4, the fraction of unbound T3 is greater than compared to that of the unbound T4. But there is less unbound T3 in the circulation. Why? Because T3, it is produced in smaller amounts and it is cleared more rapidly than compared to that of T4. That is the reason why the unbound T3, it is present in lesser quantity than compared to that of the unbound T4. Okay, so this is about the story of the protein binding capacity of your thyroid hormone. So whenever you test for the thyroid hormone levels, you have to test total T4, total T3, and then FT3, FT4. That is free T3 and free T4 means the one which is not bound to the proteins. So you take unbound or free concentration of the hormone, that is almost nearly 2 into 10 to the power of 11 moles for T4 and 6 into 10 to the power of 12 moles for T3. So majority of thyroid hormone which is available is in the form of the bound form, whereas if you take the unbound form, the unbound or free concentration of hormone is very less. If you take T4, it is 2 into 10 to the power of 11 moles for T4, and if you take T3, 6 into 10 to the power of 12 moles for T3. So this is the one which is unbound form, and it is the unbound form which is biologically active, right? So which is biologically active is the unbound hormone. Okay, now so this is the basic physiology of thyroid hormone. After this, now let me explain you about the T3, T4, TSH, what will happen in patients with the thyroid related disorders. So you see this question here, laboratory investigation of a patient shows decreased T3, decreased T4 and decreased TSH. The question is, it cannot be. The options are primary hypothyroidism, panhypopituitarism, secondary hypothyroidism, none of the above. The answer to this question is primary hypothyroidism, right? I'm just giving you the answer and now I'll give you the explanation. So first of all, you should know what is primary and as well as secondary thyroid related disorders. So if the pathology is in the thyroid gland, right? If the pathology is in the thyroid gland, this we call it as primary thyroid related disorders, right? For suppose, if the pathology is in the pituitary gland, anterior pituitary, or if the pathology is in the hypothalamus, then we call it as secondary or tertiary thyroid related disorders. Primary pathology is in the thyroid gland. Secondary and tertiary pathology is in the anterior pituitary or within the hypothalamus. Now let me explain you what will be T3, T4, TSH in primary and as well as secondary thyroid related disorders. Primary hypothyroidism. Where is the problem? The problem is within the gland. So accordingly, what will happen to your T3, T4? T3, T4 will be reduced. So when T3, T4 is reduced, what will happen to your TSH? The TSH will be increased. Why? When T3, T4 is reduced, there will be inhibition of negative feedback mechanism. So TSH will increase. And you take secondary hypothyroidism. The pathology is directly within the pituitary gland. So what will happen to your TSH? The TSH decreases. So accordingly, what will happen to your T3, T4? T3, T4 will be reduced. That is what will happen in secondary hypothyroidism. And you take primary hyperthyroidism. Primary means the pathology is in the gland. So in primary hyperthyroidism, T3, T4 will be increased. right? T3, T4 will be increased. So when T3, T4 is increased, what will happen to the TSH? The TSH will be decreased. Okay, why? Because of the negative feedback mechanism, the TSH will be reduced. And you take in patients with the secondary hyperthyroidism. In secondary hyperthyroidism, the pathology is in the anterior pituitary. Anterior pituitary is producing excess amount of TSH. When anterior pituitary is producing excess amount of TSH, accordingly, what will happen to your T3, T4? Increases. So, this is what is your T3, T4, TSH in primary and as well as secondary hypo and as well as hyperthyroidism. Now, followed by that, the other important question is the best marker to diagnose thyroid related disorders. T3, T4, TSH, thyroglobulin. Please remember, the best marker to diagnose thyroid related disorder is the TSH. Okay, so currently TSH is the most important test for determining the thyroid dysfunction in both hypothyroidism and as well as the hyperthyroidism. And this has been made possible by the improvement in the sensitivity of the TSH measurements over the years. So, what is that sensitivity of the TSH measurements? Let me just show you. Now, you see this question. Which of the following most closely represents the lowest detection limit for the third generation TSH assay? The options are 0.4 milliunits per liter, 0.04 milliunits per liter, 0.004 milliunits per liter, 0.0004 milliunits per liter. So, first of all, you should know what is the normal TSH value. The normal TSH value is 0.5 milliunits to 5 milliunits per liter. Right, 0.5 to 5 milliunits per liter. That is a normal TSH value. Now, in third generation TSH assay, what will be the close correlation? What is closely represents? Now, let me explain you what is your first generation, what is your second generation, and what is the third generation TSH assay. First of all, for suppose if the TSH is decreased, what does it represents? It represents two disorders. Either it should be secondary hypothyroidism, right, or it should represent primary hyperthyroidism. Right, it should represent secondary hypothyroidism or primary hyperthyroidism. That is what is the meaning of this decreased TSH. Now, what will happen, what is the problem in first generation, second generation, and why are we following this third generation? Let me explain you. You take the first generation TSH assay. Okay, before that, what is the normal value? 0.5 to 5 milliunits per liter. Now, if you take the first generation TSH assay, the lower limit of first generation TSH assay is 1 milliunit per liter. Right, the lower limit is 1 milliunit per liter. That is a lower limit. That means what? Whatever might be the TSH of the individual, like for example, the TSH of the individual is 0.1 milliunits per liter. Right, TSH of the individual is 0.1 milliunits per liter. Even though the patient's TSH is 0.1, if you do the first generation TSH assay, right, if you do the first generation TSH assay, it will give you the value as 1 milliunit per liter itself. It will give you the value as 1 milliunits per liter itself. For example, the patient might be having 0.05. If you do first generation TSH assay, it will give you the value as 1 milliunits per liter only. It will not detect less than 1. That means the problem with your first generation is the maximum it can detect is up to 1, not less than 1. So, by your first generation TSH assay, which particular thyroid disorders can be missed? You will miss secondary hypothyroidism or you will miss the primary hyperthyroidism. So, your first generation TSH assay has been taken off. Later came the second generation TSH assay. So, normal value is 0.5 to 5. Later came the second generation TSH assay. So, in the second generation TSH assay, the lower limit is 0.1 milliunits per liter. That is the lower limit for second generation TSH assay. What is the normal value? 0.5 to 5. That means what? The second generation TSH assay, it can detect, right? It can detect your secondary hypothyroidism, and it can also detect primary hyperthyroidism. Right? It can also detect the primary hyperthyroidism. That is what can be detected by the second generation TSH assay. You can diagnose secondary hypothyroidism and you can also diagnose primary. But the problem is with the second generation TSH assay, the severity of thyroid related disorders cannot be assessed. Right? The severity cannot be assessed. That means what? For example, the patient is having the TSH of 0.01 milliunits per liter. Right? The patient is having TSH of 0.01 milliunits per liter. Patient is having 0.01, but with the help of second generation, it will give you the value as 0.1 itself. Right? With the help of second generation, it will give you the value as 0.1 itself. That means what? Severity of thyroid related disorders cannot be diagnosed. That is what is the problem with the second generation TSH assay. Now later, we have third generation TSH assay. Third generation TSH assay, lower limit is 0.01 milliunits per liter. Right? Lower limit is 0.01 milliunits per liter. So, your third generation TSH assay can diagnose severity of secondary hypothyroidism, can also diagnose severity of primary hyperthyroidism. Okay, that is the importance of third generation TSH assay. So, you see the question now. Which of the following most closely represents the lowest detection limit of third generation TSH assay? The answer is 0.04. Actually, it is 0.01. But what is given asked to you most closely represents, right? Most closely it can detect up to 0.01, which is nothing but your 0.04, right? So this is a very important method, the third generation TSH assay. See, this third generation TSH assay, we also call this as chemiluminescent assay, right? So third generation TSH chemiluminescent or chemi-illumianometric assay. This is currently in wide use for the detection of the TSH and to diagnose hyperthyroidism and as well as the hypothyroidism. Now, followed by that, the other important methods for diagnosing thyroid related disorders are by using radioactive iodine uptake studies. Now, what is the radioactive iodine uptake we use that is iodine 123 or iodine 132. Right, iodine 123 or iodine 132 is used for diagnosis of the thyroid related disorders. And out of these, you take iodine 123. Iodine 123, the half-life is around 8 hours. And iodine 132, the half-life is 2.3 hours. Right, 2.3 hours. So, we have one more form of radioactive iodine, that is iodine 131. So this iodine 131, it is useful for therapeutic purpose. Right, it is useful for therapeutic purpose. Okay, now let me explain you about the nodules with your radioactive iodine. Nodules that produce excess thyroid hormone. See, actually, whenever you do radioactive iodine uptake studies, what is that you will have is, you have what is called hot nodules and as well as the cold nodules. Now, what are these? Nodules that produce excess thyroid hormone, they are called the hot nodules. right? Nodules that produce excess thyroid hormone, that is called the hot nodules. And they show up on the scan because they take up more of the isotope than normal thyroid tissue does. And these hot nodules, remember, they are non-cancerous. Right? They are non-cancerous. In some cases, nodules that take up less of the isotope, right? Nodules, they take less of the isotope. They are called cold nodules. And these cold nodules, right? These cold nodules, they are cancerous. Okay. So, hot nodules, remember, they are just only the overactive tissue. Cold nodules, remember, it is your cancerous tissue. And if it is just a warm nodule, it is the normal uptake. Now, let me tell you the conditions where you have high radioactive iodine uptake and conditions where you have low radioactive iodine uptake. Now, you see this table, this is very, very important. Conditions where you have high radioactive iodine uptake. First and foremost, very important is your Graves' disease. So, Graves' disease, this is the most common cause of hyperthyroidism, right? And this Graves' disease, this is also an autoimmune disease where you have the formation of thyroid stimulating immunoglobulins in the Graves' disease, okay, where you have high radioactive iodine uptake. Toxic nodule. Toxic nodule, it is like the autonomic thyroid tissue. So these toxic nodules will be producing excess amount of T3, T4, and these are the nodules which take up high amount of the radioactive iodine uptake. That is your iodine 123 or iodine 132. And other conditions where you have high radioactive iodine uptake is autonomous nodular goiter, metastatic follicular thyroid carcinoma, then HCG dependent hyperthyroidism of trophoblastic diseases, TSH secreting pituitary adenoma. So TSH secreting pituitary adenoma, this is called thyrotroph type of pituitary adenoma. So these are all the conditions where you have high radioactive iodine uptake. And conditions where you have low radioactive iodine uptake is mainly thyroiditis. So subacute thyroiditis, it is nothing but secondary to viral infections, that is secondary to your upper respiratory tract infections. There you have low radioactive iodine uptake. And this subacute thyroiditis, this is also called as the de Quervain's thyroiditis. And other conditions where you will have low radioactive iodine uptake is lymphocytic thyroiditis, postpartum thyroiditis, exogenous hyperthyroidism, which is also called factitious hyperthyroidism, then recent iodine load. So these are all the conditions where you have low radioactive iodine uptake. Now, apart from this, even the USG abdomen is also very important for the diagnosis of thyroid related disorders. Now, what is the importance of the USG abdomen? Mainly for diagnosis of the ovarian malignancies like stroma ovarian. So this particular stroma ovarian, it is a clinical condition which will make the individual to land up in the hyperthyroidism. So these are your investigations for diagnosis of thyroid related disorders. So it is your T3, T4, TSH, then followed by radioactive iodine uptake studies, then followed by the ultrasound abdomen, and then you have certain disorders where you have to test for the antibodies. Like I'll just show you one particular clinical condition, that is Hashimoto's thyroiditis. You see this question, Hashimoto's thyroiditis, all are true except neutrophilic infiltration, maximum incidence in child, painless in thyroid, none of the above. So answer to this question is the neutrophilic infiltration. I will explain you and once again come back to this question for you. So what is your Hashimoto's thyroiditis? It is a condition which is characterized by an autoimmune disease. Right? It's an autoimmune disorder. And this is the most common cause of primary hypothyroidism in India. Whereas, if you see most common cause of primary hypothyroidism globally, it is your iodine deficiency, right? It is your iodine deficiency, that is global. And this Hashimoto's thyroiditis, remember, it mainly affects the middle-aged females. Right, mainly affects the middle-aged females. So although it is primarily a disease of middle-aged females, it can occur in children, and it is the major cause of non-endemic goiter in children. So it can occur in children as well. Right, it can occur in children as well. That is what is your the Hashimoto's thyroiditis. Now, if you take the histopathology of the Hashimoto's thyroiditis, it is a disorder where you have diffuse enlargement of thyroid gland. Right, where you have diffuse enlargement of the thyroid gland. And this particular diffuse enlargement, whatever is there, it is, right, it is painless swelling. Right, it is not painful swelling, it is painless swelling of the thyroid gland. Now, why is there diffuse enlargement? What happens in the histopathology? Let me explain you. So, in Hashimoto's, there will be infiltration of the lymphocytes. Right, there is lymphocytic infiltration of the gland. Right, there is lymphocytic infiltration of the gland. And these lymphocytes, whichever have infiltrated, they produce the antibodies. I'll give you the list of antibodies. These antibodies, they will destroy the follicular cells. Right, they will destroy the follicular cells. And apart from destroying the follicular cells, there are few surviving follicular cells. Few surviving follicular cells, they are filled with abundant pink cytoplasm. Right, few surviving follicular cells, they are transformed into large cells. Surviving follicular cells, they fuse and they transform into large cells, and they are filled with abundant pink cytoplasm. Right, they are filled with abundant pink cytoplasm. And these surviving follicular cells with abundant pink cytoplasm, they are known as the Hurdle cells. Right, they are known as Hurdle cells. So Hurdle cells are nothing but the surviving follicular epithelial cells that are transformed into large cells with abundant pink cytoplasm. They are known as the Hurdle cells. Now, let me tell you what are these antibodies. I said you that antibodies, they are the one which will destroy the follicular epithelial cells. So, these particular antibodies, they are IgG type of antibodies. Right? They are your IgG antibodies. Now, what is the name of these particular IgG antibodies? They are anti-thyroglobulin antibody, right? Anti-thyroglobulin antibody, then antimicrosomal antibody, then antibody directed against component of colloid, right? Antibody directed against the component of colloid, and antibody directed against TSH receptors, right? Antibody directed against TSH receptors. These are the antibodies in Hashimoto's. And remember, these particular antibodies, they do not correlate with severity of the disease. Right? They do not correlate with the severity of the disease. These antibodies, they are of diagnostic value. Right? These antibodies, they are of diagnostic value. Okay. So that is very, very important in the pathogenesis of the Hashimoto's thyroiditis. And clinical features, as already I have said you, it is painless swelling of the thyroid gland. Right? It is painless swelling of the thyroid gland. And commonly, this will present with hypothyroidism. Right? Commonly, this will present with hypothyroidism. And very rarely, these patients with Hashimoto's, they can present with transient hyperthyroidism. Right? They present with transient hyperthyroidism. So this hyperthyroidism will be there for a short period of time. Transient hyperthyroidism. And this transient hyperthyroidism of Hashimoto's, this is called Hashitoxicosis. Right? This is called Hashitoxicosis. Okay. So this is about the basic introduction and the features of the Hashimoto's thyroiditis. I'll just show you one more question. Laboratory investigation of a patient shows decreased T4 and increased TSH. Which of the following is most likely diagnosis? Graves' disease, Hashimoto's disease, pituitary failure, hypothalamic failure. The answer to this question is the Hashimoto's disease. In Hashimoto's, there is decreased T4 and increased TSH. Right? Decreased T4 and increased TSH. Okay. Whereas you take in Graves, there will be increased T3 and as well as T4, and there will be decreased TSH. That is what you will have in Graves. You take in pituitary failure. In pituitary failure, there will be decreased TSH, decreased T3 and decreased T4. That is what you will have in pituitary failure. You take in hypothalamic failure, there will be decreased thyroid releasing hormone, decreased thyroid stimulating hormone, and there will be decreased T3 and as well as decreased T4. So that is what you will have in the hypothalamic failure. Okay. So this is about the T3, T4, TSH in various thyroid related disorders. Now, after this, let me explain you what are the etiologies which will cause the hypothyroidism. So, after having discussed about the etiologies causing hypothyroidism, we have discussed one of the very important etiology, that is Hashimoto's thyroiditis. Hashimoto's thyroiditis, that is the most common cause for primary hypothyroidism in India. Now, what are the other causes for the hypothyroidism? The other causes include iatrogenic causes. So, the iatrogenic causes include, number one, iodine-131 therapy. See, in the patients with hyperthyroidism who is not able to get managed with the medical management, we give iodine-131 treatment. This iodine-131, if it is given in excess doses, it can make the individual to land up in permanent hypothyroidism. That is iatrogenic cause. And the other important iatrogenic cause is subtotal or total thyroidectomy. So, in case of goiter, a large goiter which is causing the pressure symptoms on the esophagus or trachea, that has to undergo resection. So, when you do a total or subtotal thyroidectomy, the individual may land up in hypothyroidism. And the third one is external irradiation of neck, for lymphoma. So these are the iatrogenic causes for hypothyroidism. Then, followed by this iatrogenic causes, next we have the drugs causing hypothyroidism. Now, let me tell you what are the drugs which will cause hypothyroidism. Very important group of drugs is anti-thyroid group of drugs. So, what are these anti-thyroid group of drugs? They include thyroid peroxidase inhibitors. Examples: methimazole, carbimazole, and propylthiouracil. That is your anti-thyroid drugs. And the next important drug is lithium. Lithium, it is a drug used in the treatment of bipolar disorders which will cause the hypothyroidism. Next we have para-aminosalicylic acid. Next we have interferon alpha. Next we have a drug used in the treatment of renal cell carcinoma that can cause hypothyroidism, and that includes sunitinib. And we have also a drug which we were using previously for the treatment of Cushing syndrome, that is aminoglutamide. Right? So these are some of the drugs which can cause the hypothyroidism, right? And apart from that, we also have cytokines. So these drugs makes the individual to develop primary hypothyroidism. Now, after these drugs, let me tell you some more causes for primary hypothyroidism. That is congenital hypothyroidism. So, if you take congenital hypothyroidism, in this, it is due to mutation of TSH receptor on the follicular cells of thyroid gland. Okay, so that is what is your congenital hypothyroidism. So, in congenital hypothyroidism, it is due to mutation of the TSH receptors which are present on the follicular cells. So, due to mutation of the TSH receptors on the follicular cells, the TSH will not act on the TSH receptors. Then, followed by that, we have infiltrative disorders causing primary hypothyroidism. Now, what are these infiltrative disorders causing primary hypothyroidism? That includes number 1, amyloidosis. Right? Number 2, the sarcoidosis. Number 3, cystinosis. Right? Next we have Riedl's thyroiditis. Next we have scleroderma. So these are the infiltrative pathologies. You take amyloidosis. In amyloidosis, abnormal proteins, they get infiltrated into the thyroid gland, and that makes the individual to land up in hypothyroidism. You take sarcoidosis. In sarcoidosis, it is the non-caseating granuloma. Right? Non-caseating granuloma that will get infiltrated into the thyroid gland, and that makes the individual to land up in hypothyroidism. Cystinosis, it is the abnormality associated with the cysteine amino acid. And one more infiltrative disorder we have, that is hemochromatosis. So, in hemochromatosis, please remember, it is abnormal infiltration of iron into the gland wherein the thyroid gland will not function properly because of excessive accumulation of iron in the thyroid gland. Next is scleroderma. In case of scleroderma, it is the abnormal collagen which gets accumulated into the thyroid gland. And in Riedl's thyroiditis, it is abnormal fibrous tissue which will get accumulated into the gland. So these are the infiltrative disorders causing the hypothyroidism. So we have iatrogenic causes, drugs causing hypothyroidism, congenital hypothyroidism, and infiltrative disorders. Then followed by that, you should know what are the causes for secondary hypothyroidism. See, for secondary hypothyroidism to occur, the pathology should be at the level of the pituitary gland. Right, the pathology should be at the level of pituitary gland. Now, which particular pathology of the pituitary gland can make the individual to land up in hypothyroidism? That includes pituitary surgery, right? Number 2, infiltrative disorders. Right, infiltrative disorders into the pituitary gland. Then Sheehan syndrome. So what is this Sheehan syndrome? It is postpartum hypopituitarism. That is your Sheehan syndrome. Then trauma to the pituitary gland. So these are all the conditions which will affect the pituitary gland that will result in secondary hypothyroidism. Right? That will result in secondary hypothyroidism. Then, followed by the conditions discussed about secondary hypothyroidism, let me tell you what are the conditions which will cause tertiary hypothyroidism. See, for tertiary hypothyroidism to occur, the pathology should be at the level of hypothalamus. So, if the pathology is at the level of hypothalamus, that will cause decrease in the TRH production. Right? That will cause decrease in TRH production, that is thyroid releasing hormone secretion. Now, what are the causes of hypothalamus causing tertiary hypothyroidism is tumors of the hypothalamus, then trauma to the hypothalamus, then infiltrative disorders. Right? Infiltrative disorders. So, these are the causes for tertiary hypothyroidism, that is, the disorders associated with hypothalamus. Right? Disorders associated with the hypothalamus. Now, after having discussed about the etiologies causing hypothyroidism, let me tell you there are certain food substances or food goitrogens which can cause hypothyroidism, and that too particularly the primary hypothyroidism. And that particular food goitrogens, they are present in turnips and as well as the cassava beans, right? So these can cause the primary hypothyroidism. Now, after having discussed about the etiologies causing hypothyroidism, let me tell you let me discuss the etiologies causing hyperthyroidism. So, you see this question, most common cause of hyperthyroidism is, the options are thyroid hyperplasia, thyroid adenoma, thyroid carcinoma, Graves' disease. Let me tell you, the most common cause for hyperthyroidism is your Graves' disease. Now, Graves' disease, what type of disorder is this? It is an autoimmune condition. Let me discuss now. Let me discuss all the etiologies causing the hyperthyroidism. So first we have autoimmune conditions, that is Graves. And please remember, Graves' disease, this is the most common cause of hyperthyroidism. Right, most common cause for primary hyperthyroidism. Now, this is an autoimmune disorder. So, in this disorder, it is characterized by production of autoimmune antibodies. And these autoimmune antibodies are thyroid stimulating immunoglobulins. right? These are thyroid stimulating immunoglobulins. So your Graves' disease is a condition which will cause hyperthyroidism, which is an autoimmune condition, which is the most common cause for hyperthyroidism. And one more autoimmune condition which will cause hyperthyroidism is Hashimoto's. That is, Hashimoto's thyroiditis. In early stages, it will cause transient hyperthyroidism. For a short period of time, it will cause hyperthyroidism and then followed by that hypothyroidism. So that is what is called as Hashimoto's. Then followed by the autoimmune conditions, we have autonomous thyroid tissue. Now what is this autonomous thyroid tissue? Autonomous thyroid tissue is the clinical scenario where thyroid gland on its own, it will produce excess amount of T3 and as well as T4. This autonomous thyroid tissue is not dependent on the TSH which is coming from the anterior pituitary. Okay. Now what are the conditions where you have autonomous thyroid tissue? That includes number 1, toxic adenoma, and number 2, toxic multinodular goiter. Right, toxic multinodular goiter. So these are the two autonomous thyroid conditions which will cause the hyperthyroidism. They are tumors basically, or they are not dependent on the TSH which is coming from the anterior pituitary. On their own, they will be producing excess amount of T3 and as well as T4. Then we have TSH mediated hyperthyroidism. Thyroid stimulating hormone is the hormone which is coming from the anterior pituitary. Now, the tumors of the anterior pituitary, right? Which particular tumor? That is pituitary adenoma. And what type of pituitary adenoma is this? It is thyrotroph type of pituitary adenoma. Right? Thyrotroph type of pituitary adenoma. So thyrotroph type of pituitary adenoma will produce excess amount of TSH, and that excess amount of TSH will go and act on follicular cells, and that will result in the hyperthyroidism. And the next important etiology is the HCG mediated hyperthyroidism. So what is this HCG mediated hyperthyroidism? More and more HCG being produced that can cause hyperthyroidism. Now, how is this? Human chorionic gonadotrophin, it has the structure similar to that of TSH, right? And this HCG can stimulate the thyroid follicular cells similar to that of TSH. Okay, so that is what is called the HCG mediated hyperthyroidism. Now, what are the conditions where there is excessive production of the human chorionic gonadotrophin? That is hyperemesis gravidarum, and second condition where there is excessive HCG production is trophoblastic diseases. Okay, so these are HCG mediated hyperthyroidism, that is hyperemesis gravidarum and as well as the trophoblastic diseases. Then followed by that, we have certain conditions causing thyroiditis which will cause the hyperthyroidism. So what are those conditions which will cause thyroiditis causing hyperthyroidism? Number 1, subacute granulomatous thyroiditis. So this subacute granulomatous thyroiditis, this is also called de Quervain's thyroiditis. Right, this is also called de Quervain's thyroiditis, and it is secondary to viral infections. It will cause viral thyroiditis. So please remember this. Your viral thyroiditis, that is de Quervain's, it is tender swelling of thyroid gland will be there in case of subacute granulomatous thyroiditis, which we will discuss that in detail. Now we have another form of thyroiditis called painless thyroiditis. This painless thyroiditis, which is also called silent thyroiditis, it is due to lymphocytic infiltration, which we call it as lymphocytic thyroiditis. Then we have a very important drug which can induce thyroiditis and can make the individual to land up in hyperthyroidism, that is amiodarone. So amiodarone, it is a class 3 anti-arrhythmic drug. It can cause both hyperthyroidism and as well as hypothyroidism. So amiodarone induced thyroid disorders, we will discuss that in detail again. Then we have radiation thyroiditis. Right, we have radiation thyroiditis. Then palpation thyroiditis. So in palpation thyroiditis, what will happen is, like there is a large goiter, and on repeated palpation of that particular large goiter, the individual can progress to develop hyperthyroidism. That is called palpation thyroiditis. Now we also have many infections, which I will discuss that. Infections also will cause thyroiditis causing hyperthyroidism. Now after that, the other etiologies causing hyperthyroidism is exogenous thyroid hormone supplementation. That is excessive replacement therapy. Right, that is excessive replacement therapy. So in these individuals with the excessive replacement therapy, the individual is advised to be taken like 50 micrograms. But instead of 50 micrograms, if the patient is taking 150 micrograms of thyroid, that will make the individual to land up in the hyperthyroidism, right? And lastly, ectopic hyperthyroidism. So these are some of the causes of your hyperthyroidism. But one point you should know is about the thyroiditis. So thyroiditis, if you see, it can be acute, subacute or chronic thyroiditis. Let me show you that. You take the conditions causing acute thyroiditis. It could be secondary to bacterial infection, fungal infection, radiation thyroiditis or amiodarone-induced thyroiditis. So these are all the etiologies which will cause acute thyroiditis. But if you take subacute thyroiditis, which is of less severe form, that is secondary to your viral infection, right? That is decurvain thyroiditis. Next, silent thyroiditis, right? Which is nothing but postpartum thyroiditis or lymphocytic thyroiditis. Then secondary to mycobacterial infection, you can have this thyroiditis. And next, drug-induced thyroiditis, that is interferon or the amiodarone. So that is about the subacute thyroiditis. Then followed by that we have chronic thyroiditis. Chronic thyroiditis, the examples include the autoimmune conditions like Hashimoto's thyroiditis, focal thyroiditis, atrophic thyroiditis, riddles, parasitic and the traumatic after palpation. These are all the things which will cause chronic thyroiditis. Okay. Now apart from this, right, so there are certain conditions causing thyroiditis with hyperthyroidism manifestations. There are certain conditions causing thyroiditis with hypothyroidism manifestations, right? Now, after having discussed about this thyroiditis causing hypo and hyperthyroidism, let me tell you, in females, there is a tumor of the ovary which can cause hyperthyroidism, right? And what is that particular tumor of the ovary which will cause hyperthyroidism in females is, that is stroma ovary, right? That is stroma ovary. Now, what is this particular stroma ovary? It is an ovarian tumor defined by the presence of thyroid tissue comprising more than 50% of the overall mass. So, in this stroma ovary, there is more than 50% of thyroid mass. So, this stroma ovary, it is most commonly occurs as a part of teratoma. Right, it most commonly occurs as a part of teratoma. And although stroma ovary usually does not secrete thyroid hormones, there are cases in which it produces thyroid hormones, which results in the hyperthyroidism. So in order to look for stroma ovary, like you can do an ultrasound of the abdomen to make out the diagnosis of this stroma ovary. Okay, next. And apart from that, we have what is called certain drugs which can induce the hyperthyroidism apart from your amiodarone, right? Apart from the amiodarone. And what is that particular drugs? That is ipoprostenol. So ipoprostenol, it is a prostaglandin. Administration of ipoprostenol may cause hyperthyroidism. Right, may cause hyperthyroidism. Now, the next thing you see, iodine-induced hyperthyroidism. See, iodine-induced hyperthyroidism, it is although uncommon, it can develop after a iodine load. As an example of after the administration of the contrast agent used for angiography or CT or iodine-rich drugs such as amiodarone. Okay, so iodine-induced hyperthyroidism, it can develop after an iodine load, and this iodine load can be in any form, either in the form of contrast agent which you give during angiography or in the form of drugs like amiodarone. Now, exogenous and as well as the ectopic hyperthyroidism. So this is from excess thyroid hormone originating outside the thyroid gland that will result in the hyperthyroidism. And we have another terminology called thyrotoxicosis factitia. See, thyrotoxicosis produced due to ingestion of excess amount of exogenous thyroid hormone is called thyrotoxicosis factitia. So, this is due to excessive consumption of, right, this is due to excessive consumption of exogenous thyroid hormone. Okay, so that is what is your thyrotoxicosis factitia. Okay, and what are the scenarios where you have this exogenous thyroid hormone supplementation is like in some individuals they take ayurvedic medications or homeopathic medications for the weight loss, and this ayurvedic or homeopathic medications, they contain levothyroxine, and this levothyroxine, what it will do, it will increase the basal metabolic rate of the individual and it will cause the weight loss of the individual. So thyrotoxicosis factitia, as such the individual doesn't have any problem, but because due to excess exogenous thyroid hormone supplementation or excess thyroid hormone intake, the individual will end up in hyperthyroidism, that is called thyrotoxicosis factitia. So these are all the etiologies which will cause the hyperthyroidism. So etiologies causing hyperthyroidism, one is your autoimmune, then autonomous thyroid tissue, that is toxic adenoma and toxic multinodular goiter, then TSH mediated hyperthyroidism, that is pituitary adenoma, HCG mediated hyperthyroidism, that is hyperemesis gravidarum and trophoblastic diseases, and thyroiditis like decurvance thyroiditis, palpation thyroiditis, painless thyroiditis, radiation thyroiditis, and amiodarone-induced thyroiditis, and then exogenous thyroid hormone intake. Now, after having discussed about the conditions causing the hyperthyroidism, let me tell you the decurvance thyroiditis in detail. So if you take this decurvance thyroiditis, as already I have mentioned, it is viral in origin. Right, it is viral in origin, and this particular decurvance thyroiditis, it follows, right, it follows upper respiratory tract infection, right, it follows upper respiratory tract infection. And the clinical features of this decurvance thyroiditis is they will have pain over the thyroid, right, they will have pain over the thyroid, and the pain is also present in the lower jaw, ear, and as well as the occiput. Right? These are the sites of pain in case of the decurving thyroiditis. And in these patients, the thyroid, it is irregular and firm. Right? It is irregular and firm in consistency, and it is enlarged. Right? And it is enlarged. Okay? And these individuals, they will have fever, malaise, and as well as weakness or asthenia. Okay, so these are the clinical features. Now, apart from that, if you take the investigations in these individuals, decurving thyroiditis, ESR will be elevated, right? Erythrocyte sedimentation rate will be elevated. And if you take the radioactive iodine uptake studies, so radioactive iodine uptake will be depressed. And if you take the T3, T4 levels, in early stages, there will be mild thyrotoxicosis. Right? There will be mild thyrotoxicosis. Right? In early stages. Right? Then followed by that, as the time progresses, later the individual will have hypothyroidism. So in early stages, why there will be thyrotoxicosis? That is because of release of the thyroid hormone or leakage of the thyroid hormone from the gland. The T3, T4 levels will be increased. Right? T3, T4 levels will be increased. But later, once the store is completely depleted, the individual will end up in the hypothyroidism. And if you take the histology of this Hashimoto's thyroiditis, there will be presence of multinucleated giant cells. Right? There will be presence of multinucleated joint cells. That will be the histology in patients with the decurving thyroiditis. Now, if you take the prognosis in these individuals, they have a good prognosis. Right? They have a very good prognosis. The hypothyroidism or hyperthyroidism, whatever it is, it returns back to the normal function in these patients with the decurving thyroiditis. Okay. Now, the other forms of the thyroid related disorders, we have two other important forms, that is Jod-Base-Dose effect and Wolff-Chaikoff effect. What is that? Let me discuss. So, you see the question here, the occurrence of hyperthyroidism following administration of supplemental iodine to subjects with endemic iodine deficiency goiter is known as. Options are Jod-Base-Dose effect, Wolff-Chaikoff effect, thyrotoxicosis factitia, decurving thyroiditis. The answer to this question is Jod-Base-Dose effect. Right? The answer to this question is the Jod-Base-Dose effect. See, Jod-Base-Dose effect, it is iodine-induced hyperthyroidism. Right? So, iodine-induced hyperthyroidism, that is what is your Jod-Base-Dose effect. And this may occur in patients with multinodular goiter. Okay? Jod-Base-Dose will occur in patients with multinodular goiter. Right? Now, after an intake of large amount of iodine, right? After an intake of large amount of iodine. So, how will be this intake of large amount of iodine? That can be in the form of diet. That can be in the form of radiographic contrast material. right? And that can be in the form of the drugs like amiodarone. So these are all the ways by which the iodine can be supplemented in large amounts within the individual. So in a patient with multinodular goiter, after an intake of iodine, the individual may land up in hyperthyroidism. That is called iodine-induced hyperthyroidism, and that is what is called as jod-base dose disease. Right? That is what is called as jod-base dose disease. Now, here what happens is the contrast agents and other iodine-containing substances, they should be avoided because of risk of inducing the jod-base dose effect. So please remember, an individuals with large multinodular goiter and that too autonomous nodules, the contrast agents and as well as the iodine containing substances, they should be avoided. That is what is called as the jod-base dose effect. Now you see another question, that is Wolff-Chaikoff effect. Wolff-Chaikoff effect, you see the options: excess iodine intake causes hypothyroidism, iodine-induced hyperthyroidism, thyrotoxicosis due to excessive amount of iodine ingestion, drug-induced hyperthyroidism. Remember, Wolff-Chaikoff effect, excess iodine intake transiently inhibits thyroid iodide organification. So, Wolff-Chaikoff effect is excess iodine-induced hypothyroidism. Right? Excess iodine-induced hypothyroidism. That is what is your Wolff-Chaikoff effect. So, why there is hypothyroidism here? That is because this excess iodine intake transiently inhibits transiently inhibits thyroid iodide organification. Okay, so that is what is your Wolff-Chaikoff effect. So this phenomenon of iodine dependent transient suppression of thyroid, right? This phenomenon of iodine dependent transient suppression of thyroid is called as the Wolff-Chaikoff effect. And why is this Wolff-Chaikoff effect due to? That is due to inhibition of thyroid iodide organification. So what is organification? In organification, there will be binding of iodine with the thyroglobulin, and that will result in the formation of monoiodotyrosine or diiodotyrosine. That is what is called organification, and in the presence of the enzyme thyroid peroxidase, and this particular step will be inhibited. Right, this particular step will be inhibited in case of the Wolff-Chaikoff effect. Okay, and that will result in Wolff-Chaikoff effect. Now let me discuss about the drug which will alter the thyroid function. See, the drug which will alter the thyroid function, options are like quinidine, flecainide, amiodarone and disopyramide. Please remember, the answer is the amiodarone. So amiodarone, it can alter the thyroid function. See, this amiodarone, it can cause either of it. It can cause hypothyroidism, or this can cause the hyperthyroidism. Right, this can cause the hyperthyroidism. So this amiodarone associated thyroid disorders, like for example amiodarone associated hypothyroidism, this is more common in women. Right, this is more common in women, and this is also more common in individuals with positive TPO antibodies. Okay, so it is very common in women, and it is also common in individuals with positive TPO antibodies. And amiodarone, as already we have discussed, it is class 3 anti-arrhythmic drug. Right, it is your class 3 anti-arrhythmic drug. Now, what is the mechanism? See, amiodarone will cause hypothyroidism in one or two mechanisms. What is that? I will discuss. The first important thing is amiodarone will inhibit an important enzyme called deiodinase. And where is this deiodinase required? This deiodinase, it is required for the conversion of T4 to T3. That is, you require 5-deiodinase. Right, you require 5-deiodinase. Okay, so this enzyme is inhibited by your amiodarone, and thereby your T4 is not converted into T3. Right, your T4 is not converted into T3. That is one mechanism. And another mechanism for the development of the amiodarone-induced hypothyroidism is that this amiodarone, it will cause thyroid hormone unable to get escaped from the follicular cells. That is, you see here. So, amiodarone associated hypothyroidism involves an inability of the thyroid to escape from the high iodine load. Consequently, amiodarone associated hypothyroidism is more common in women and in individuals with positive TPO antibodies. This already I have discussed. Right? So, to summarize the mechanism of the amiodarone induced hypothyroidism, we have two mechanisms. What is that? Number one, inhibitory effect of iodine on T4 release. See, amiodarone is a substance, or amiodarone is the drug which has iodine, and the iodine which is present in the amiodarone will inhibit the release of T4 from the follicular cells. That can cause hypothyroidism. And second important thing is, the amiodarone, it is inhibiting enzyme called 5-deiodinase. Thereby, T4 is not converted into T3. And another important thing is, the amiodarone can induce the Wolff-Chaikoff effect. What is that? It can inhibit thyroid iodide organification. Organification, just now we have discussed. Thyroglobulin, when it combines with iodine, that will result in monoiodotyrosine and diiodotyrosine. So, you see the three mechanisms now. Number one, the amiodarone will inhibit the organification. That is Wolff-Chaikoff effect. Amiodarone, it has inhibitory effect on the T4 release. Amiodarone, it has the inhibitory activity on 5-deiodinase. So, by all these, what will happen now? There will be increased T4. Why increased T4? Because T4 is not converted into T3 because of the absence of your 5-deiodinase. There is increased T4 and decreased T3 because T3 is not formed. Why T3 is not formed? Because you don't have this deiodinase enzyme. Because this deiodinase enzyme is inhibited by your amiodarone. So this is the mechanism for amiodarone-induced hypothyroidism. To summarize, it has inhibitory activity on 5-deiodinase. It has inhibitory activity on the T4 release from the follicular cells. Number 3, it will inhibit the organification. Right? Now, then amiodarone can also cause the hyperthyroidism. So this amiodarone-induced hyperthyroidism, it is of two types. Right? Amiodarone-induced hyperthyroidism, it is of two types. That is, we have AIT1, amiodarone-induced thyroiditis, or amiodarone-induced thyrotoxicosis type 1, and amiodarone-induced thyrotoxicosis type 2. Right? So these are the two types of the amiodarone-induced thyroidism or thyrotoxicosis. Now, let me explain you the differences. Amiodarone-induced thyrotoxicosis type 1, it is associated with an underlying thyroid abnormality. So, there is an underlying thyroid abnormality. Whereas you take amiodarone-induced thyrotoxicosis type 2, it is associated with an individuals with no intrinsic thyroid abnormality. Right, with no intrinsic thyroid abnormality. Whereas AIT1, it is associated with an underlying thyroid abnormality. Okay, next. Now, the other differences are, in AIT1, thyroid hormone synthesis becomes excessive as a result of increased iodine exposure. That is your JOD based dose. So, amiodarone-induced thyrotoxicosis type 1, the basic principle is JOD based dose phenomenon. So, JOD based dose, just now we have discussed. What is that? It is iodine-induced hyperthyroidism. The same principle is your amiodarone-induced thyrotoxicosis type 1. Now, in these individuals with amiodarone-induced thyrotoxicosis type 1, these thyroid gland, they have increased vascularity. Right, these thyroid gland, they have increased vascularity. So this increased vascularity, how can you make out that there is increased vascularity? That is seen on the color flow Doppler. Right, that is seen on the color flow Doppler. And you take the inflammatory mediators, that is interleukin 6. Interleukin 6 levels, they are marginally raised. Right, they are marginally raised. That is what is your amiodarone-induced thyrotoxicosis type 1. It is seen in the pre-existing thyroid abnormalities. The basic principle for the development of hyperthyroidism is JOD based dose. Color flow Doppler will show increased vascularity of the thyroid gland. Interleukin 6 levels are raised. And you take amiodarone-induced thyrotoxicosis type 2. There is no intrinsic thyroid abnormality here. Here, thyrotoxicosis results from drug-induced lysosomal activation leading to destruction of the thyroid. Okay, so it is, right, it is drug-induced lysosomal activation. Right, drug-induced lysosomal activation leading to destruction thyroiditis. Okay, and this amiodarone-induced thyrotoxicosis type 2, this can resolve spontaneously, or occasionally it will lead to hypothyroidism, but most of the times it will resolve spontaneously. And if you take the color flow Doppler in amiodarone-induced thyrotoxicosis type 2, color flow Doppler, it shows decreased vascularity. Right, you see the difference. Amiodarone-induced thyrotoxicosis type 1, it shows increased vascularity on color flow Doppler, whereas AIT2, it shows decreased vascularity on the color flow Doppler. And even in AIT2 also, the interleukin 6 levels, they are raised. Right, interleukin 6 levels, they are raised. So this is about the amiodarone-induced hypothyroidism and as well as hyperthyroidism. So we are done with the etiology of hypo and as well as hyper. To summarize, most common cause of hypothyroidism in India, Hashimoto's. Most common cause of hypothyroidism globally, iodine deficiency. Then you take hyperthyroidism. Most common cause of hyperthyroidism is Graves' disease. Okay, so now let me move on to the discussion of clinical features in hyperthyroidism and as well as hypothyroidism. I'll just compare the clinical features of hyper and as well as hypo with the basic physiology of thyroid hormone. So now let me discuss the clinical features in patients with the thyroid related disorders. So you just see a question here. What is a true statement about the thyroid storm? Bradycardia, hyperthermia, hypercalcemia, hypotension, cardiac arrhythmias. So the answer to this question is hyperthermia, hypercalcemia, and the cardiac arrhythmias. Okay. Now let me just discuss the thyroid related disorders, clinical manifestations, and then we will come back to this question once again. So clinical manifestations, let me explain you by comparing hyperthyroidism and hypothyroidism. So on one side you take hyperthyroidism and on other side take hypothyroidism, right? And you should know the basic physiology of thyroid hormone. So thyroid hormone, please remember what is the effect of it on the basal metabolic rate of the individual. Thyroid hormone, it increases the basal metabolic rate. That is a basic physiology. You take in hyperthyroidism, what will happen? In hyperthyroidism, there will be excessive increase in the basal metabolic rate, and because of excessive increase in the basal metabolic rate, the individual will have weight loss. Right? The individual will have profuse sweating. Right? The individual will have heat intolerance. Right? And the individual will also have increased appetite. Right? So these are the manifestations of increased BMR in hyperthyroidism. And you take in hypothyroidism, it is exactly opposite. In hypothyroidism, the BMR will be grossly reduced. So in hypothyroidism, the individual will have weight gain. And if you take the skin of these individuals, they'll have dry skin. And if you take the heat intolerance, you will have that in hypothyroidism. Right? Heat intolerance you will have in hyperthyroidism, whereas in hypothyroidism, you will have cold intolerance. Whereas in hypothyroidism, if you take the appetite, there will be decreased appetite. Right? There will be decreased appetite. So that is what is the difference between hyperthyroidism and as well as hypothyroidism based on the basal metabolic rate of the individual. Now you take on the carbohydrate metabolism. Please remember, on the carbohydrate metabolism, thyroid hormone, it will increase gluconeogenesis. That is the effect of the thyroid hormone on the glucose metabolism, right? So right, it increases the gluconeogenesis. And not only that, this particular thyroid hormone will also increase the glucose absorption as well. So in hyperthyroidism, what will happen accordingly? In hyperthyroidism, immediately after taking food, the individual will suffer with hyperglycemia. Right? The individual will suffer with hyperglycemia. And why is this particular hyperglycemia? That is because of increased gluconeogenesis. In the sense, whatever the non-carbohydrate moieties that have been taken in the food, they are converted into glucose, and thereby the individual will develop hyperglycemia. Right? So plasma glucose level rises rapidly after taking a meal in hyperthyroidism. But in hypothyroidism, you don't have change. There will not be any hypoglycemia because you have many other counter regulatory hormones which will maintain the blood glucose level within the individual with hypothyroidism. Next, you take on the lipid metabolism. Please remember, thyroid hormone, it will cause lipolysis. right? Thyroid hormone, it will cause lipolysis, wherein the fat is broken down into free fatty acids, right? Fat is broken down into free fatty acids. In hyperthyroidism, what will happen? There is excessive lipolysis, right? There is excessive lipolysis. So because of this excessive lipolysis, more and more free fatty acids are produced, right? And what will happen to your triglycerides? They are reduced. What will happen to your cholesterol? That will be reduced. That is what will happen in hyperthyroidism. But whereas you take in patients with hypothyroidism, in hypothyroidism, lipolysis is reduced, right? Lipolysis is reduced. So as the lipolysis is reduced, what will happen to your triglycerides? It increases. What will happen to your cholesterol? It increases, right? Triglycerides and as well as cholesterol, it increases in hypothyroidism. And because of this increased triglycerides and because of increase in the cholesterol, they are prone for severe atherosclerosis, right? They are prone for severe atherosclerosis. That is what you will observe in patients with the hypothyroidism. And because of this severe atherosclerosis, they can also develop coronary artery disease, right? Now, then followed by that, you take the protein metabolism. Thyroid hormone, it will cause proteolysis. And where are the proteins which are present in our body? They are present within the skeletal muscle, right? They are present within the skeletal muscle. So in hyperthyroidism and hypothyroidism, what will happen? So in hyperthyroidism, there is excessive proteolysis, right? Because of excessive proteolysis, the individual will have proximal muscle weakness in patients with hyperthyroidism. Whereas in hypothyroidism, the protein metabolism within the muscle doesn't occur. So that is the reason why the individual will have muscle fatigue, because there is no production of ATP at all within the muscle in patients with your hypothyroidism. Okay, so that is the reason why there is muscle fatigue. So we have discussed carbohydrate, lipid and protein metabolism abnormalities in both hypo and as well as hyper. Now let me discuss the cardiovascular system manifestations in hypo and as well as hyper. So for that you should know the basic physiology first. Thyroid hormone, please remember, it increases the heart rate of the individual, it increases the cardiac output of the individual, it increases velocity of the conduction, and it also increases excitability of the heart, right? It also increases the excitability within the heart. Now apart from this, thyroid hormone will increase the systolic blood pressure and thyroid hormone will decrease diastolic blood pressure, right? Will increase systolic blood pressure and it will decrease the diastolic blood pressure. That is what is being done by your thyroid hormone. Now in hyperthyroidism, what will happen? In hyperthyroidism, the heart rate abnormally increases, and that is the reason why the individual will have tachycardia. And because of this tachycardia, the individual will have palpitations, right? The individual will have palpitations. And remaining parameters, excitability is increased, velocity of conduction is increased. In hyperthyroidism, they are excessively increased, and the individuals, they are more prone for arrhythmias. And which type of arrhythmias are more common? Most common type of arrhythmia is your atrial fibrillation. Now in atrial fibrillation, what do you think will be the pulse in these individuals? They will have irregularly irregular pulse. right? That is a characteristic pulse in patients with atrial fibrillation, irregular pulse. Then followed by that, in these individuals, there will be increase in the systolic blood pressure. Why? Because thyroid hormone increases the systolic blood pressure. So the patients will have systolic hypertension, right? The patients will have systolic hypertension. Okay. Then followed by that, you take the activity of the heart. There will be hyperdynamic heart. Right? It will be hyperdynamic heart. Now, because of this particular hyperdynamic heart, the individual will land up in high output heart failure. So, in patients with hyperthyroidism, there will be hyperdynamic heart failure. And another important cardiac manifestations in hyperthyroidism is that when you auscultate the heart in patients with hyperthyroidism, you will listen an ejection systolic murmur, which is nothing but a mid-systolic murmur. And there is a name for this mid-systolic murmur. And the name of this mid-systolic murmur, it is called as means Lerman scratch. Right? It is called as the means Lerman scratch. This is a named murmur, which is a very important multiple choice question. Next. And in the basic physiology of thyroid hormone in the cardiovascular system, what is that I have discussed over the blood pressure? It will increase the systolic blood pressure and it will decrease the diastolic blood pressure. That is what we have discussed in the basic physiology. So in hyperthyroidism, the individual will have the systolic hypertension, right? And what will happen to the diastolic blood pressure? The diastolic blood pressure will be reduced. So overall, what will happen to the pulse pressure of the individual? There will be increase in the pulse pressure of the individual. Right? So overall, there will be increase in the pulse pressure of the individual. And in these patients with hyperthyroidism, the individual can develop the angina. So these are the cardiac manifestations in patients with the hyperthyroidism. Now, after having discussed about the cardiac manifestations in hyperthyroidism, let me discuss what will be the cardiac manifestations in hypothyroidism. So, in hypothyroidism, it will be exactly opposite to that of the hyperthyroidism. First and foremost, the heart rate. The individual will have bradycardia. So if thyroid hormone is there, that is the one which will increase the heart rate of the individual. If thyroid hormone is reduced, the individual will have decrease in the heart rate of the individual. Next, the other important point is the diastolic blood pressure. If thyroid hormone is there, what will happen to the diastolic blood pressure of the individual? There will be decrease in the diastolic blood pressure of the individual. And if thyroid hormone is not there, that can make the individual to land up in diastolic hypertension. Right, that can make the individual to land up in the diastolic hypertension. And in these patients with hypothyroidism, the individual can also have the AV block. And the individual will also develop pericardial effusion. Okay, so these are the cardiac manifestations in patients with the hypothyroidism. Alright, so this is about the cardiovascular manifestations in hyper and as well as the hypothyroidism. Then, followed by that, you need to know what will be the respiratory manifestations in patients with the thyroid disorders. In thyroid disorders, okay, first of all, you should know the basic physiology of the thyroid hormone on the respiratory centers. Remember, this thyroid hormone, it will stimulate the respiratory centers. Right, it will stimulate the respiratory centers. Alright, now what are the respiratory centers? Like we have the apneustic center and pneumotaxic center within the pons. Then we have dorsal respiratory group and ventral respiratory group within the medulla oblongata. These are the respiratory centers, and thyroid hormone will stimulate the respiratory centers. Okay. Now, in patients with hyperthyroidism, what will happen? In patients with hyperthyroidism, there will be excessive activation of the respiratory centers, and thereby there will be increase in the respiratory rate of the individual. So, which is nothing but tachypnea. So, if you take the normal respiratory rate, the normal respiratory rate will be around 12 to 18 breaths per minute. That is a normal respiratory rate. Okay. Now, you take in hypothyroidism, what will be the respiratory manifestations? Please remember, in hypothyroidism, thyroid hormone is not there and it will not stimulate the respiratory center, and thereby the individual will land up in respiratory failure. And what type of respiratory failure the individual develops in hypothyroidism? The individual develops type 2 respiratory failure. Now, what do you understand by this terminology, type 2 respiratory failure? In patients with type 2 respiratory failure, they have hypoxemia and they'll have the hypercapnia. That is what type 2 respiratory failure is. Now, actually we have 4 types of respiratory failure. Type 1 respiratory failure, it is just only acute hypoxemia, right? Basically hypoxemia, but carbon dioxide levels, it may be normal or decreased in type 1 respiratory failure. Type 2 respiratory failure, it is hypoxemia and as well as the hypercapnia. Type 3 respiratory failure, it is atelectasis. That is your type 3 respiratory failure. Then we have type 4 respiratory failure. It is due to hypoperfusion of the respiratory muscles. That is your type 4 respiratory failure. Now, then let me tell you what will be the gastrointestinal manifestations in thyroid disorders. First of all, you should know the basic physiology. The basic physiology is that the thyroid hormone will stimulate the gastrointestinal motility. Right, will stimulate the gastrointestinal motility. And not only that, the thyroid hormone will also increase the secretion of digestive juice. That is the basic physiology of thyroid hormone on the GAT. So accordingly, in patients with hyperthyroidism, what will happen? The gastrointestinal motility is grossly increased, and that is the reason why the individual will have diarrhea in patients with the hyperthyroidism. Whereas you take in patients with hypothyroidism, the gastrointestinal motility is reduced, and that can make the individual to land up in constipation. Right, that can make the individual to land up in constipation. So in hyperthyroidism there is diarrhea, and in hypothyroidism the individual will have constipation. Then followed by that, what will be the effect of thyroid related disorders on central nervous system? And you should know again the basic physiology. See, thyroid hormone, what it will do to the central nervous system is that it will increase the rapidity of cerebration. Right, it will increase the rapidity of cerebration. That is what is the basic physiology. So in case of hyperthyroidism, what will happen? There is excessive cerebral neuronal stimulation, and that is the reason why in patients with hyperthyroidism they will have extreme nervousness. Right, they have extreme nervousness, and then followed by that they also have psychotic tendencies, and they also have the anxiety complexes. Right, they also have the anxiety complexes, and these patients, they have the tendency of extreme worry. Right, the tendency of extreme worry. So that is about the CNS manifestations in hyperthyroidism. And not only that, these patients, they also have tremors. And how can you elicit the tremors? You should ask the individual to outstretch the hand. So once the individual outstretches the hand, you can elicit the presence of the tremors over the fingers. And in hypothyroidism, what will happen? There will be decreased cerebration, right? In the sense, there will be decreased cerebral neuronal stimulation. The individual will be dull and lethargic. Right? The individual will be dull and as well as lethargic. And the very important CNS manifestation in hypothyroidism is that in patients with hypothyroidism, you have the presence of hunger reflexes. Right? You have the presence of the hunger reflexes. Now, what is this hunger reflex? You will have this hunger reflex over the ankle jerk. Right? And what is this particular, the hunger reflex within the ankle jerk? See, in patients with hypothyroidism, they will have myxedema of Achilles tendon. Right? There will be myxedema of the Achilles tendon. And because of the myxedema of the Achilles tendon, these individuals, they will have delayed relaxation. Right? They'll have delayed relaxation of the deep tendon reflexes. That is what is called as the hunger reflex. Right? That is called as the hunger reflex. And this hunger reflex is the most reliable sign in patients with the hypothyroidism. Okay? And these hunger reflexes, let me tell you, you will also have in patients with the chorea. Alright? Now, so this is about the CNS manifestation in hypothyroidism and as well as the hyperthyroidism. Now, followed by that, what will happen to the sleep of the individual in patients with the hyperthyroidism? See, thyroid hormone has the exhausting effect on the musculature, exhausting effect on the CNS, central nervous system of the individual. So, thyroid hormone, it has the exhausting effect. Why? Because even thyroid hormone will also increase the basal metabolic rate of the individual. It will increase the CNS activity. So that is the reason why in patients with hyperthyroidism, the individual is extremely exhausted, excessively exhausted. So that is the reason why in patients with hyperthyroidism, there is extreme fatigability. Right? There is extreme fatigability, but the individual is unable, or the individual will have inability to sleep. Right? The individual will have inability to sleep. That is what you will have in patients with the hyperthyroidism. They'll have difficulty in sleeping. Why? Because this in hyperthyroidism, that increased thyroid hormone will excessively stimulate the cerebral neurons. So even though the individual is extremely fatigued, the individual cannot sleep. Whereas in patients with hypothyroidism, because thyroid hormone is not there, there is no stimulation of your cerebral neurons. These individuals, they have excessive sleep. So the hypothyroid patients, they have extreme somnolence. They sleep nearly around 12 to 14 hours per day if they are not being disturbed. That is what is the manifestation in patients with the hypothyroidism. Then followed by that, yes, the skin. See, skin in hyperthyroidism, it will be yellowish in color. Now, why is this particular skin yellowish in color in patients with hypothyroidism? That is because of the carotenemia. Let me explain you what is this carotenemia. See, if thyroid hormone is there, right, if this particular thyroid hormone is there, your beta carotene in the liver, it is converted into vitamin A. That is what is the function of the thyroid hormone. Now in hypothyroidism, what will happen? Your thyroid hormone, right? Thyroid hormone, it is reduced. So if thyroid hormone is reduced, the conversion of beta carotene to vitamin A does not occur. Right? If thyroid hormone is reduced, conversion of beta carotene to vitamin A does not occur. So thereby there will be increase in the beta carotene levels. Right? Thereby there will be increase in the beta carotene levels. Now this beta carotene will go and get deposited within the skin of the individual, and that will give yellow color to the skin of the individual. Right? That will give yellow color to the skin of the individual. But how will you differentiate this from jaundice? Remember, in case of the beta carotenemia, the sclera will be normal. Right? The sclera will be normal. Whereas, you take in patients with jaundice. In patients with jaundice, the skin is yellowish, and even the sclera is also yellow in color. Right? The sclera is also yellow in color. That is what you will observe in patients with jaundice. Right? That is what you will observe in patients with jaundice. Okay? So that is about the skin in patients with jaundice. Now, after having discussed about the skin, now you should know about what will happen to the muscular system in patients with the thyroid disorders. See, you take a muscle. Muscle is made up of the protein. And what is the effect of thyroid hormone on the protein? It will cause proteolysis, that is protein catabolism. So, if you take on muscular system, see, on muscular system, you should know that thyroid hormone will cause thyroid hormone will cause the proteolysis. Okay, so that means the protein catabolism. So in hyperthyroidism, what will happen? In hyperthyroidism, remember that there is excessive proteolysis. And because of this excessive proteolysis, the individual will have the proximal muscle weakness. Because muscle is made up of a protein. Okay, so there will be proximal muscle weakness. That is what you will have in patients with hyperthyroidism. Whereas in patients with hypothyroidism, there is no protein metabolism at all in the muscle. The individual will have extreme muscular sluggishness. Right? Extreme muscular sluggishness. That is what you will have in patients with the hypothyroidism. Now, so we have discussed on muscular system what will be the clinical manifestation in hyper and as well as the hypothyroidism. Now, very important thing in the thyroid disorders, we need to know about what is this called as the Pemberton sign. What is this Pemberton sign? Let me explain you. This Pemberton sign, you will have that in patients with the retrosternal goiter. So in retrosternal goiter, whenever the individual raises the arm, alright, so on raising the arm of the individual, there will be facial congestion. Right, there will be facial congestion. That is what is called as the Pemberton sign. And this retrosternal goiter, it is evaluated by CT or the MRI of the chest. Okay, so you can make out here, this is your retrosternal goiter. So that is what is your Pemberton sign. Next, very important thing, in patients with hypothyroidism, they will have galacturia. Now, why does this patient of hypothyroidism has galacturia? And that too, you will have that in patients with primary hypothyroidism. Now, why is that? Because in patients with primary hypothyroidism, there will be increase in the thyroid releasing hormone from the hypothalamus. And this increased thyroid releasing hormone that will go and stimulate the anterior pituitary, right? That will go and stimulate the anterior pituitary gland to produce not only TSH, this increased TRH will also produce the excess amount of prolactin. And that is the reason why the individual will have galacturia. See, for an individual to have hyperprolactinemia, there are two important systemic conditions. One is your primary hypothyroidism and the other one is in chronic renal failure. Even in chronic renal failure also, the individual has the hyperprolactinemia. Right? Why? Because in chronic renal failure, there is no excretion of your prolactin. And that is the reason why that will cause hyperprolactinemia and as well as the galacturia. Alright? Next. Then followed by that, what will happen to the reproductive system in patients with the thyroid related disorders? So, if you take on the reproduction or on the sexual function, what will happen in patients with hyperthyroidism? In patients with hyperthyroidism, they will have infertility. And in patients with hypothyroidism, what will be the manifestation? The most common menstrual irregularity, what you will have in females, will be menorrhagia. So menorrhagia, this is the most common menstrual irregularity you will have in females. Whereas, apart from menorrhagia, less commonly, there can be even amenorrhea, where there is absence of menstruation, or there can be even oligomenorrhea. Right, so this is less common. Right, this is less common. That is what you will have in patients with the hypothyroidism. So this is what is the sexual function or the reproductive abnormalities in the thyroid related disorders. Now, after having discussed about the galacturia and as well as the reproductive system abnormalities, let me tell you what will happen to the skin in patients with the thyroid related disorders. We have a clinical condition called as the infiltrative dermopathy. This infiltrative dermopathy, this will occur in almost 5 to 10% of patients with Graves' disease. Right, it is seen in almost 5 to 10% of patients with the Graves' disease. And most of the time, this infiltrative dermopathy, it is accompanied by severe ophthalmopathy. Right, it is accompanied by severe ophthalmopathy. And what is that ophthalmic manifestations we will discuss. But this infiltrative dermopathy, we call it as the pretibial myxedema. This pretibial myxedema, let me tell you, it is seen in both hyperthyroidism and as well as hypothyroidism. But most commonly it is seen in patients with the hyperthyroidism, that is Graves' disease. And this infiltrative dermopathy, it is rarely reported in Indian patients. And what will be the features of this, the pretibial myxedema or infiltrative dermopathy? The features include these individuals, they can have non-pitting edema, right? Non-pitting type of edema. There will be induration of the skin, right? There will be induration of the skin on the legs. And which part of the legs? That is mainly over the shin of the tibia. And that is the reason why this is called as the pretibial myxedema. It can occur even in other sites also, but most commonly over the shin of the tibia. And this is commonly seen in the Graves rather than the hypothyroidism. So this is about your infiltrative dermopathy. Next, and I said you this infiltrative dermopathy, most of the times it is accompanied by ophthalmopathy. Now let me explain you about this infiltrative ophthalmopathy. See, infiltrative ophthalmopathy is in the sense where the individual will have proptosis. And this particular proptosis is the protrusion of the eyeball. So why does this infiltrative ophthalmopathy occurs? So if you take the orbital adipose tissue and as well as the extraocular tissues, they are inflamed. Okay, so in infiltrative ophthalmopathy, extraocular and orbital adipose tissue both of these, they are inflamed, right? Both of these, they are inflamed, and not only inflamed, and okay, why are they inflamed, or like why are they swollen? That is because of the accumulation of the glycosaminoglycans, right? And where is this glycosaminoglycans coming from? These glycosaminoglycans, they are secreted by the fibroblasts, right? They are secreted by the fibroblasts. And why is this fibroblast secreting the glycosaminoglycans? In patients with the Graves disease, there is release of the cytokines, and these cytokines, they stimulate the fibroblasts to release glycosaminoglycans. These glycosaminoglycans, they will cause the inflammation of the extraocular and as well as the orbital adipose tissue. And which group? See, I have already said you that infiltrative ophthalmopathy is seen in patients with the Graves, but it is not seen in all patients of the Graves. What is the risk factor for the development of ophthalmopathy in Graves? It is smoking. Okay, so smoking is considered an important risk factor for the development of ophthalmopathy in the Graves disease. So if you take this thyroid ophthalmopathy, according to American Thyroid Association, they have classified this thyroid ophthalmopathy. So the mnemonic for the thyroid ophthalmopathy is no specs. And what is this no specs stands for? Let me discuss this. So the word N, these individuals, they don't have eye signs or symptoms. And you take the word O, they have only signs, there are no symptoms. And what is that particular only sign? That is the stare sign, right? That is your stare sign. Okay, so the individual will have a staring look. And you take the word S, S stands for soft tissue involvement, where there is presence of signs and as well as the symptoms. And the word P, no specs, P. The word P is your proptosis, where there will be protrusion of eyeball for more than 22 mm. That is your proptosis. The word E is your extraocular muscle involvement. And remember, the most common extraocular muscle which is involved is inferior rectus muscle. And because of the involvement of the inferior rectus muscle, the individual will have the diplopia. And no specs. The word C stands for the corneal involvement. Right? The word C stands for the corneal involvement. And lastly, the word S stands for the loss of sight. And this particular loss of sight is due to the optic nerve involvement, where the individual will develop the retrobulbar neuritis. So this is what is your no specs classification of thyroid associated ophthalmopathy. So this completes the discussion of the clinical manifestations in hypo and as well as hyperthyroidism. And following that, let me discuss the extreme forms of hypo and as well as hyperthyroidism. So if you take the extreme form of hyperthyroidism, that is called thyroid storm. And if you take extreme form of hypothyroidism, that is called myxedema coma. So let me discuss now this thyroid storm and as well as the myxedema coma. So after having discussed about the clinical manifestations in patients with the hypothyroidism and as well as hyperthyroidism, now let me take up the treatment of the hypo and as well as the hyperthyroidism. Now we will start that with a question, a clinical question. I have a 40-year-old female patient who is a known case of the ischemic heart disease, and she is diagnosed as having the hypothyroidism. Which of the following would be the most appropriate line of management for her? The options are: start levothyroxine at low dose, do not start levothyroxine, use levothyroxine, thyroid extract is a better option. So now what do you think is the answer? Right? The answer is you need to start levothyroxine at low dose. Now why is that we need to start levothyroxine at the low dose? Let me discuss. Okay. So before going on to the discussion of levothyroxine replacement in patients with an ischemic heart disease, let me discuss the levothyroxine replacement in a normal hypothyroid individual, that is non-cardiac patient with hypothyroidism. And then I will also discuss how will you treat the hypothyroidism in pregnancy, and later on I will also take up like how do you treat hypothyroidism in patients with the ischemic heart disease. So you take in otherwise healthy young and middle-aged adults with hypothyroidism. They may be treated initially with levothyroxine in average doses of about 1.6 micrograms per kg per day. Okay. So in a healthy young individual, right, where you don't have any cardiac abnormality in them, the levothyroxine, so levothyroxine is your T4, that has to be started is at a dosage of 1.6 micrograms per kg per day, right? So that is a dosage in a healthy young individual who is like middle-aged adult. Now lower doses can be used for very mild hypothyroidism. Like if the individual is having mild hypothyroidism, then in such case lower doses can be used in mild hypothyroidism, whereas like full dose should be used in case of severe symptomatic hypothyroidism. Right, severe symptomatic hypothyroidism, we give full dose of this levothyroxine, that is 1.6 micrograms per kg per day. Then this is like in healthy young individuals like who is of middle age. Whereas what should be the dose of the levothyroxine in a pregnant woman? See, pregnant women with overt hypothyroidism or myxedema, they should be treated immediately with levothyroxine at full replacement. Okay. So once you diagnose that pregnant woman is hypothyroid, the treatment with levothyroxine should be started immediately. Right? And the dose what you give is the full dose. Right? And what is that and how much is that? That is 1.6 micrograms per kg per day. Now, apart from that, apart from this 1.6 micrograms per kg per day, the dose that you can give is about 100 to 150 micrograms per day can be given in a pregnant female with hypothyroidism. Now, for initial titration, the levothyroxine dosage may be increased according to the clinical response. And not only according to the clinical response, the initial titration can be done even based on the serum TSH. And this serum TSH, that has to be measured every 4 to 6 weeks. So once you start levothyroxine, the serum TSH in pregnancy has to be monitored every 4 to 6 weeks. Right? It has to be monitored every 4 to 6 weeks. Okay. Now, this target of the TSH should be in a range of, whenever you have started this levothyroxine, what should be the target TSH value? That should be around 0.4 to 2 milliunits per liter. Right? Milliunits per liter. Okay. That should be the target of your serum TSH whenever you are giving levothyroxine in a pregnant woman. Okay. Now, the initial hormonal goal of levothyroxine replacement therapy should be normalizing the serum TSH value. That should be the goal of your levothyroxine replacement. Now, when should you give this levothyroxine? This levothyroxine should be given early morning, right, in a fasting state. Now, what will happen if you give this particular levothyroxine during bedtime? Bedtime levothyroxine administration, it will result in somewhat higher serum T4 and lower TSH levels than compared to that of the morning administration. Right? So, when you give this bedtime, you will have higher serum T4 and lower TSH levels. So, that is the reason why usually bedtime administration of levothyroxine is not advised. Okay, and whenever you are administering levothyroxine, that should be administered at a constant time, right? And once you have started levothyroxine, significant increase in T4 will occur within 1 to 2 weeks. Okay, so there will be significant increase in your T4 within 1 to 2 weeks of the administration of levothyroxine, and it reaches the near peak levels. Right, it reaches the near peak levels within 3 to 4 weeks. Right, it reaches the peak levels within 3 to 4 weeks. Okay, that is what is the administration of your levothyroxine. Now, how will you administer levothyroxine in a patient with hypothyroidism with an underlying ischemic heart disease? Okay, so for that, you see this table. So, first, a patient with hypothyroidism, just you have to know whether the cardiac disease is present or not. For example, if the cardiac disease is present, yes, then in such case, you have to start levothyroxine at a lower dose. So, in patients with cardiac disease, you have to start levothyroxine at 25 micrograms per day. You should not start with higher dose. Why? Why is that we need to start with a cardiac disease with a lower dose? Why? Because in patients with ischemic heart disease, the myocardial blood supply is reduced. And whenever you give thyroxine, the myocardial activity will be increased. So, for suppose when you give 75 micrograms or 100 micrograms of thyroxine in patients with ischemic heart disease, the blood supply is less because of ischemic heart disease, but myocardial activity will be very high because of your supplementation of thyroxine. So, there will be supply and demand mismatch, and that can precipitate the underlying ischemic heart disease. And that is the reason why you should not start at a higher dose. You should start at a lower dose in a patient with an underlying cardiac disease. Whereas in those individuals who does not have any cardiac disease, then you can start with a full dose, right? The full dose is around 1.6 micrograms per kg per day, right? So this is what is the dose that you can start in a patient who is not having any underlying cardiac disease. Okay, so that is the reason why you see in this question, a patient with ischemic heart disease having hypothyroidism, what is that you need to do? You have to start levothyroxine at a lower dose, whereas use levothyroxine will be applicable in those individuals who are non-cardiac right? There is no cardiac disorder, but the patient is having hypothyroidism. Right, but the patient is having hypothyroidism. Okay, then in such case you can use levothyroxine at full dose, and not only that, even in pregnancy with hypothyroidism. Right, even in pregnancy with hypothyroidism, you need to use levothyroxine in full dose. Okay, that is about the story of your treatment of the hypothyroidism. Now, let me take up the discussion of the hyperthyroidism, the treatment of the hyperthyroidism. Okay, now you see this question first. A pregnant woman is diagnosed suffering with the Graves' disease. The most appropriate therapy for her would be radioiodine therapy, total thyroidectomy, carbimazole parenteral, propylthiouracil orally. Now, the answer to this particular question is oral propylthiouracil. Right? The answer is oral propylthiouracil. Now, in which group of individuals you have to give propylthiouracil? In which group of individuals you need to give methimazole? All that let me discuss now. Okay, right. So, first of all, I'll try to take up the treatment of hyperthyroidism during pregnancy. So, if you take during pregnancy, like we have 3 trimesters, first trimester, second trimester, and as well as third trimester. You take in the first trimester, the drug of choice for hyperthyroidism is propylthiouracil. Right, the drug of choice is propylthiouracil. So, whereas you take in second and third trimester, right, you take in case of second and third trimester, here the drug of choice will be methimazole if the pregnant female is having hyperthyroidism. Okay, in the first trimester, propylthiouracil, and in second and third trimester, that is methimazole. So please remember now, one more important point. Both men and women with Graves' disease who are planning pregnancy, that is, the women planning pregnancy should not have radioactive iodine treatment within about 4 months of conception. This is a very, very important point. Please remember that. So, radioactive iodine should not be administered in men and women with Graves' disease who are planning pregnancy within 4 months of conception. Right, so within a period of 4 months of conception, individual should not take this radioactive iodine. Very, very important point. Why? Because this radioactive iodine is associated with increased risk of the congenital anomalies. Right, it is associated with congenital anomalies. Okay, right. Now, coming to the propylthiouracil and as well as the methimazole. Both of them, they are your thioureas, right? That is thyroid peroxidase inhibitors. That is thyroid peroxidase inhibitors. So, these thyroid peroxidase inhibitors are the one which are encouraged in women who are planning to become pregnant, right? But they should not be given radioactive iodine. Okay. Now, why you should give the propylthiouracil in the pregnancy? Right, why you should give propylthiouracil? Okay, whatever you are giving propylthiouracil, the dosage of propylthiouracil is 50 to 150 milligrams daily. Right, 50 to 150 milligrams daily to avoid goiterous hypothyroidism in the infant. This is the dose. But in second and third trimester, it is switched to methimazole. Now, what is the rationale behind that? The point is that, first of all, propylthiouracil, it has the short half-life. So, it has to be administered almost 3 times to 4 times per day. But methimazole, it has long T-half. It is the advantage of methimazole. Then why can't you give methimazole in the first trimester? The problem is that methimazole, it is teratogenic. Right? Methimazole, it is teratogenic. So, methimazole being teratogenic cannot be given in the first trimester. Why? Because the first trimester of the pregnancy is where the organogenesis will occur in the baby. So, that is the reason why you cannot give methimazole, because it is being teratogenic in the first trimester. Whereas propylthiouracil, it is not teratogenic. Right? It is not teratogenic. Then why don't you continue propylthiouracil in the remaining trimesters of pregnancy? Right? Why don't you continue propylthiouracil in the remaining trimesters of pregnancy? Because this propylthiouracil is associated with an important adverse effect, that is acute liver failure. Right? It is associated with acute liver failure. That is the reason why we don't continue propylthiouracil in second and as well as the third trimester. And if you take the dosage of methimazole, the dosage of methimazole is 5 to 15 milligrams per day. Right? 5 to 15 milligrams per day. That has to be given in the second and as well as third trimester. Okay, next. Now, I said you that methimazole, it is teratogenic. Now, what is the teratogenicity associated with methimazole? That we call it as methimazole embryopathy. Now, within the skin, the teratogenicity associated with methimazole is aplasia cutis, right? There is no skin formation, in the sense the skin formation is incomplete. So, the gut abnormalities are the choanal atresia and as well as the omphalocele. The cardiac abnormalities with methimazole is the ventricular septal defect, and the abnormalities within the face will be dysmorphic facies. So, these are the teratogenicity associated with the methimazole. And now, other important point is that what will happen to the fetus? Whenever you are giving this methimazole or like propylthiouracil in the pregnancy, what will be the effect of those drugs to the fetus? Okay. You should remember one important point, that propylthiouracil and as well as methimazole, right, as well as methimazole, both of these drugs, they cross the placenta. Right, both of these drugs, they cross the placenta and they can induce hypothyroidism. Right, they can induce hypothyroidism. So, if they can induce hypothyroidism in the fetus, if you take the fetal TSH, the fetal TSH, it will be increased. Right, so there will be fetal TSH hypersecretion and there can be even the development of goiter. Right, even there can be development of goiter. So, when you do a fetal ultrasound, right, when you do a fetal ultrasound at 20 to 32 weeks, right, at 20 to 32 weeks gestation, you can visualize if there is presence of any fetal goiter. Right, you can visualize if there is any presence of the fetal goiter, allowing fetal thyroid dysfunction to be diagnosed and treated. And whenever you give thyroid hormone administration to the mother, that does not prevent hypothyroidism in the fetus. So, consider that the fetus has developed hypothyroidism because of your propylthiouracil and methimazole. So, when you supplement thyroid to the mother, that does not prevent hypothyroidism in the fetus. Why? Because your T3 and T4 do not cross the placenta. Right? Do not freely cross the placenta. And you have to remember one important point is that the fetal hypothyroidism, right? The fetal hypothyroidism is very rare if mother hyperthyroidism is controlled with small doses of your propylthiouracil. So when you are giving propylthiouracil at a dosage of 50 to 150 milligrams per day, and when you are giving methimazole of 5 to 15 milligrams per day orally, the development of the fetal hypothyroidism is rare. Okay, so that is about the drug treatment in pregnancy, first trimester, second trimester, and third trimester. Now, in pregnant females, there are certain indications where you need to do subtotal thyroidectomy. Now, what are the indications for subtotal thyroidectomy in pregnant women with Graves' disease? So, subtotal thyroidectomy is indicated for pregnant women with Graves or for fertile women of reproductive age who are sexually active and decline contraceptives under the following circumstances. So, what are the indications? Number one, if there is severe adverse effects of thyroid peroxidase inhibitors, right? That is thioureas. So if there is severe adverse effects like agranulocytosis, pancytopenia, acute liver failure with your propylthiouracil, so when the individual develops severe adverse reactions, then you have to go ahead with the subtotal thyroidectomy. Now, apart from that, for example, if the requirement of your thioureas, right, if it is a very high dosage, right, high dosage requirement of high dosage requirement of the thioureas, then in such case also you need to do subtotal thyroidectomy, because when you give high dosage of thioureas, that can cause fetal hypothyroidism. So that is the reason why you should not give a high dosage of the thioureas. Like for example, methimazole greater than 30 milligrams per day, propylthiouracil greater than 450 milligrams per day. If the requirement is such high, then you have to go ahead with the subtotal thyroidectomy. Next, followed by that, if there is uncontrolled hyperthyroidism due to non-adherence to thiourea therapy, then also you need to do subtotal thyroidectomy. Okay, so uncontrolled hyperthyroidism due to non-adherence to thiourea therapy. These are the indications for subtotal thyroidectomy. And in which trimester you need to do surgery? Surgery, it is best performed during the second trimester. Right, it is best performed in the second trimester. Okay, that is about like the treatment of hyperthyroidism or Graves' disease during pregnancy. Now, what about the story during lactation, that is during breastfeeding? Remember, both methimazole and propylthiouracil, both of them, they are secreted in the breast milk, but not in amounts that affect the infant's thyroid hormone levels. Okay, so your methimazole and propylthiouracil, both of them, they are secreted into the breast milk, right? They are secreted into the breast milk. Okay, but they are not secreted in amounts that affects the infant's thyroid hormone levels. So these drugs which are secreted into the milk does not change the infant's thyroid hormone levels. Okay, and no adverse reactions to these drugs have been reported in breastfed infants. right? So nothing is going to happen even to the infants as well. Recommended doses are less than or equal to 20 milligrams orally daily for methimazole. In a lactating mother with Graves' diseases, you can give up to 20 milligrams per day. And if you are giving propyl thiuracil, the dosage, it should be less than 450 milligrams per day, right, in a lactating mother. And it is recommended that medications be taken just after the breastfeeding of the baby, right? Once the baby is breastfed, then the lactating mother has to take this medication. So this is about the treatment of hyperthyroidism in pregnancy. First trimester, drug of choice is propyl thiuracil. Second and third trimester, drug of choice is methimazole, right? And the teratogenicity associated with the methimazole is your choanal atresia. Then aplasia cutis, ventricular septal defect, dysmorphic facies, okay? And with propyl thiuracil, the very important adverse effect is acute liver failure. Now, so this is about the treatment of hyperthyroidism in pregnancy. But you take the treatment of hyperthyroidism or the Graves' disease in a non-pregnant female, or the treatment of Graves' disease in a male individual. The options what we have is administration of the beta blocker. That is, you need to give propranolol. Why you need to give propranolol, I'll tell you. And measures have to be taken to decrease the thyroid hormone levels. That is, you need to give thionomides. And the other options are radioiodine ablation or the surgery. So these are the options of the treatment for Graves' disease. Now first, let me discuss about the beta blocker. So the beta blocker what we give is a propranolol. Propranolol is a non-selective beta blocker. And what is the purpose of giving this propranolol? Propranolol, it is generally used for symptomatic relief of tachycardia, tremors, diaphoresis and anxiety. Okay, so this propranolol it is for the symptomatic relief of tachycardia, tremors, diaphoresis and anxiety. Okay, but you have to remember that this propranolol, it has no effect on thyroid hormone secretion. So it does not decrease thyroid hormone secretion. Okay, only for symptomatic relief you are giving this particular propranolol. And this propranolol, it is the initial, right? It is the initial treatment of choice for thyrotoxic crisis. And this effectively treats the thyrotoxic hypokalemic periodic paralysis. Okay, so this is the initial drug of choice for thyrotoxic crisis, and this is also given in case of thyrotoxic hypokalemic periodic paralysis. Okay, that is about the propranolol. And as already I have said you, propranolol does not decrease the thyroid hormone secretion. And what is the dosage of this propranolol? The dosage of propranolol is, you have to give propranolol ER 60 milligrams orally, and that has to be given once daily or the twice daily, right? And you have to increase every 2 to 3 days to a maximum dose of 320 milligrams. Right? You have to increase this to a maximum daily dose of up to 320 milligrams. And this propranolol should be given every 12th hourly. Right? That is, BD is more preferred. Why is it given every 12th hourly? Because of the short T half. So there will be accelerated metabolism of propranolol initially. So that is the reason why you need to give twice daily. But later, once the hyperthyroidism improves, then you can give once daily. So that is about the story of propranolol. So that is the initial treatment of choice in thyrotoxic crisis and thyrotoxic hypokalemic periodic paralysis. And this is mainly for symptomatic relief. Now, coming to the thionomides, that is thyroid peroxidase inhibitors. See, you take this enzyme thyroid peroxidase. If you go back to the synthesis of thyroid hormone, thyroid peroxidase, it is required at multiple levels of the thyroid hormone synthesis. Thyroid peroxidase, it is required for the organification. Thyroid peroxidase, it is required for coupling. Thyroid peroxidase, it is required for oxidation of iodide, that is from I- to I0 or I+. So these three steps you require thyroid peroxidase. So when you give this thyroid peroxidase inhibitors, your methimazole is a thyroid peroxidase inhibitor that will inhibit the thyroid hormone synthesis. Alright, that will inhibit the thyroid hormone synthesis. Okay, now methimazole, that is the drug of choice for hyperthyroidism in patients with a Graves' disease. So remember, except during the first trimester of pregnancy, methimazole is generally preferred over propylthiouracil. Okay, why? Because your methimazole, it has a long half-life. So it is very convenient for the patient to take 2 times. But for propylthiouracil, it has a short T-half. You have to take almost like 4 times a day. And with methimazole, there is less chance of fulminant hepatic necrosis. Right, less chance of the fulminant hepatic necrosis. But your propylthiouracil, it will cause acute liver failure. That is the methimazole, it is having advantage over propylthiouracil. And methimazole therapy is also less likely to cause iodine 131 treatment failure. And what is the dosage of your methimazole in a non-pregnant female and male individual? This dosage, it will be around 30 to 60 milligrams once daily, right? Some patients with mild hyperthyroidism, they may respond even to a smaller initial doses as well. So for mild hyperthyroidism, you can give even up to 10 to 20 milligrams daily. Right? You can give even up to 10 to 20 milligrams daily. And this methimazole may be administered twice daily to reduce the risk of the gastrointestinal upset. So it has to be administered twice daily. What is the purpose of that? Mainly to reduce the GI upset. Right? That is mainly to reduce the gastrointestinal upset. Now, what are the adverse effects with this methimazole? So, first and foremost, agranulocytosis. Right? And these patients, they can also present with pancytopenia. So what will be the manifestations of this agranulocytosis? The individual can have fever. The individual can have upper respiratory tract infection. So this will be the manifestations of your agranulocytosis. And apart from that, there are certain rare adverse effects of this methimazole. And that includes serum sickness. Then cholestatic jaundice. Right, then cholestatic jaundice, and there can be alopecia where there is loss of hair, and the individual can also develop nephrotic syndrome. So these are the rare adverse effects of methimazole. So methimazole use in the first trimester, what is that I have discussed? That is associated with the teratogenicity, that is aplasia cutis and as well as choanal atresia. So if methimazole is used in the first trimester, that will be the adverse effect. But that can be used in second and third trimester, and that can be used even during the breastfeeding as well. But only thing is, whenever you are giving in breastfeeding mother or whenever you are giving in second and third trimester, the dosage should be 20 milligrams per day. You should not exceed more than 20 milligrams per day in second and third trimester of pregnancy or during breastfeeding. That's a very, very important point. And when will you reduce the dosage of methimazole? The dosage is reduced as manifestations of hypothyroidism. The dosage has to be reduced as the manifestations of hyperthyroidism once they resolve, or when your FT4 levels, when your free thyroid hormone levels, if they are getting normalized, then we reduce this particular dosage of the methimazole. Then coming to your propylthiouracil. Propylthiouracil, already we have discussed, the adverse effect is acute liver failure. And this acute liver failure, it is seen in almost 1 in 1000 patients. And that is the reason why your propylthiouracil, it is considered as second line agent or second line medication in reducing this particular hyperthyroidism. Okay, and the onset of liver toxicity, it varies from 3 days to 12 months after starting this propylthiouracil. Okay, so the individual can have severe liver toxicity, and this severe liver toxicity, development of this severe liver toxicity, it varies from it varies from 3 days to 12 months after starting propylthiouracil. Therefore, propylthiouracil is ordinarily reserved for treating women actively seeking fertility and during the first trimester of pregnancy. And for non-pregnant women, non-pregnant women and as well as in males, the dosage of propylthiouracil, you have to give 300 to 600 milligrams daily, and this has to be given in 4 divided doses. This has to be given in 4 divided doses. So that is about the story of your propylthiouracil, which is a thionamide. Now, another group of drugs like what we have in the treatment of hyperthyroidism is iodinated contrast agents. See, these iodinated contrast agents, these agents, they provide effective temporary treatment for thyrotoxicosis. They provide temporary treatment for thyrotoxicosis of any cause. And what are the examples of your iodinated contrast agents? That includes hypothyroic acid, this is one particular drug, and we have another drug called iodate sodium. Iodate sodium. So these drugs, they have to be given orally in a dosage of 500 milligrams twice daily for 3 days. Okay. Right, 500 milligrams twice daily for 3 days. Then you need to give 500 milligrams once daily. So that is what is the dosage of the hypothyroic acid or iodate sodium. Now, what is the mechanism of action of these particular drugs? These drugs, remember, they inhibit the peripheral 5-deiodinase. So we have the peripheral conversion of T4 to T3. That is, tetraiodothyronine is converted into triiodothyronine in the presence of enzyme 5-deiodinase. And this particular enzyme is inhibited by these drugs. Right, this 5-deiodinase is inhibited by this hyponoic acid and hypodate sodium, and thereby it will block the conversion of T4 to T3. So thereby what will happen to your T3 levels? The T3 levels will reduce. Okay, so these iodinated contrast agents are particularly useful for patients who are symptomatically very thyrotoxic. In those group of individuals, we use this iodinated contrast agents. Okay, next, the other drug what we have is lithium carbonate. Now, where will you use this lithium carbonate? Thioureas are greatly preferred over lithium carbonate. That is your thyroid peroxidase inhibitors. They are greatly preferred over your lithium carbonate for the medical treatment of hyperthyroidism in Graves' disease. However, this lithium carbonate may be used effectively in cases of methimazole or propyl thiouracil induced hepatotoxicity or leukopenia. So, for example, if the individual has developed adverse effect with your methimazole or propyl thiouracil, right, the adverse effects like hepatotoxicity, right, the adverse effect like leukopenia. So in these individuals, we give this lithium carbonate. So where the individual is not able to tolerate this thyroid peroxidase inhibitors, that is where we give this lithium carbonate. This lithium carbonate, it should be given in a dosage of 500 to 750 milligrams daily. Right, 500 to 750 milligrams daily, and that should be given in divided doses. Okay, next, and lithium, one important point, this should not be used in pregnancy. Right, should not be used during pregnancy. Very, very important point. Next, the other drugs what we have in the treatment of hyperthyroidism is your radioactive iodine, that is iodine 131. See, this iodine 131, they destroy the overactive thyroid tissue either diffusely. So either you can give this radioactive iodine in case of the diffuse goiter, or you can give it in toxic nodular goiter. Okay, so what they will do, they will destroy right, they will destroy the overactive thyroid tissue. But what are the precautions? Because what this radioactive iodine will do, it will be sending or it will be emitting the radiations. Now, because these radiations, they are harmful to the fetus, they are harmful to the children. Radioactive iodine should not be given to the pregnant female, should not be given in lactating mother, and should be avoided in children. Okay, so this has to be avoided in pregnancy. Next, lactating mother, and then children, because this radioactive iodine, it emits the radiation. So women whoever are taking this radioactive iodine, they are advised to avoid pregnancy for at least 4 months following this iodine 131 treatment. This is a very, very important precaution. So women taking this iodine 131 treatment should avoid pregnancy for at least 4 months after taking this iodine 131 treatment. Okay, so, and remember, a pregnancy test should be obtained within 48 hours before therapy for any women with childbearing potential, right? and men have been found to have abnormal spermatozoa for up to 6 months following iodine 131 therapy. Okay, so in men the adverse effect is abnormal spermatozoa for up to 6 months of taking this radioactive iodine 131 therapy. So that is the reason why they are advised to use the contraceptive methods during the sexual intercourse. So that is about the story of your radioactive iodine. And another very important point is the presence of the Graves' ophthalmopathy. It is a contraindication to iodine 131 treatment. Then the other modalities by which you can treat hyperthyroidism is thyroid surgery. See, surgery may be indicated for patients with the Graves' disease, but there are certain indications. So what are the indications for thyroid surgery? The indications include, number one, who are intolerant to thionamides. Right? Intolerant to thionamides. That is one point. Next, women planning pregnancy in near future. Right? So they can go ahead with the surgery. And patients who choose not to have radioactive iodine therapy, and patients with Graves' ophthalmopathy. So these are the indications for thyroid surgery. And the surgical procedure of choice is the total resection of one lobe or subtotal resection of the other lobe. That should be the surgical procedure of choice. But whenever you have done the subtotal resection, you have to ensure that 4 grams of thyroid tissue should be left behind. Right? 4 grams of thyroid tissue should be left behind. But this is like when you are doing subtotal thyroidectomy. But for suppose when you are doing total thyroidectomy of both lobes, that will possess the increased risk of hypoparathyroidism. So when you are doing total thyroidectomy, there is increased risk of hypoparathyroidism because the parathyroid glands are present just behind the lobes of your thyroid gland. So whenever you are resecting the thyroid lobes, there is a high chance that the parathyroid glands are resected out. And the another important abnormality that you can have when you are doing total thyroidectomy is there can be damage. Right? There can be damage to the recurrent laryngeal nerve, and thereby the individual can have the hoarseness of voice. So that is about your thyroid surgery. So the modalities of the treatment in hyperthyroidism, we have drugs, iodine 131 treatment, and then the thyroid surgery. And apart from that, we have few more treatment options in the treatment of the hyperthyroidism, and they include the following. Right, that is the glucocorticoids. Glucocorticoids, what is the mechanism of action is, they inhibit the peripheral conversion of T4 to T3. Right, in patients with the Graves' hyperthyroidism, when you give these glucocorticoids, they will prevent the peripheral conversion of T4 to T3 and thereby reducing the T3 levels. Lithium, already we have discussed, that will block the thyroid hormone release, but its use has been limited because of its toxicity. And other drug what we have is the cholestyramine. This cholestyramine, it is given in a dosage of 4 grams 4 times daily, and that has to be given along with methimazole. And what has been observed is whenever you are giving this cholestyramine, that will reduce T4 and as well as T3 concentration more rapidly than methimazole. So that is the reason why if you give combination of methimazole with cholestyramine, there is high chance of reduction of T3, T4 rapidly. The other drug is the carnitine. Carnitine, it is a naturally occurring peripheral antagonist of the thyroid hormone action. Right? It is a naturally occurring peripheral antagonist of thyroid hormone action. Next we have the rituximab. Rituximab, it is a monoclonal antibody that causes the peripheral B cell depletion. Right? And it can be used in the treatment in patients with the Graves' disease. That is about your rituximab. So these are all the various treatment options in the patients with hyperthyroidism. So in pregnant female, right, what is the treatment option for hyperthyroidism? That is propylthiouracil. See, why don't you go with the carbimazole? Why? Because the trimester is not mentioned here. In which trimester the pregnant female is not mentioned. So why to take risk? Better to answer with the propylthiouracil. Okay, so that is about the treatment of the hyperthyroidism. So in the next session, I will discuss the extreme forms of the thyroid disorders. That is myxedema coma, that is extreme form of hypothyroidism, and thyroid storm, that is extreme form of the hyperthyroidism. Thank you very much.